All right, our last speaker for this session is Dr. Raman Muthusamy. He is the Director for Interventional Endoscopy and the second course director in this session. He's going to be talking to us about treatment options with regard to Barrett's esophagus.
Great, thank you, Kevin. So, load up the slide. So I'm really going to focus on three main areas. Should and who should we screen for Barrett's? When should we ablate? And if so, how should we follow those patients? So I guess the key question before we talk about issues specific to screening is, should we do it at all? And the idea behind that would be that we have a good option for those people that we actually find. And I would argue that I'm not entirely sure that we actually meet that criteria at this point. And then we'll talk about who we should screen, how we do it, when we should screen them, and then how long and how often should we screen them once we start that. So should we screen? Barrett's, again, is associated, we know, with an increased risk for esophageal adenocarcinoma. Potentially this risk is up to 40-fold for that of the general population. The risk of cancer is between 0.5% and 1% per year for all comers. That includes non-dysplastic all the way to high grade if you just pool based on the percentages of each that you see. And we know it's a bad cancer. The 5-year survival for esophageal adenocarcinoma is 17%. However, most studies of patients with Barrett's have shown that it has a negligible effect on their overall mortality. Most patients of Barrett's die from something other than esophageal adenocarcinoma. And so the question is, how important is it to really find it? And so this is a nice slide that Nick Shaheen had sort of put on the pros and cons of screening. Obviously, the pros would be that, if we found this, potentially we have a strategy to reduce esophageal cancer deaths. That we'd have the ability to provide patients with risk quantification. We'd say, look, you have this much length and this degree of dysplasia, and therefore your risk is X. And then for those who think they might have Barrett's, you'd give them sort of evidence either that they do, and most importantly, for those who don't, you'd give them evidence that they don't. Now, the harms of screening are that we're not exactly sure how good surveillance our current strategy is. It's certainly going to increase our direct costs of care and potentially the indirect costs of care as well. Our current strategy of screening is based on GERD, and I'm going to show you that is not always going to catch all the patients. In fact, it's going to miss the majority of the patients who have Barrett's. There's risks, of course, associated with our current standard of screening, which involves endoscopy. There's potential for false positive and false negatives, and you might say, well, gee, how am I going to get a false sort of positive? I see the Barrett's, and I'll sort of show that because a lot of people are biopsying within the cardia, and you can get cardiointestinal metaplasia. So if you don't sort of properly locate your landmarks, you can get false positives. And of course, hopefully with insurance reform, this won't be as issue, but there are issues of risks of labeling and insurability in the past. So let's say we decide we should screen, then who should we screen? In the United States at present, we think that Barrett's is present in somewhere between 1% and 2% of the US population. There was a recent study suggested that it could be as high as 3 to 3.5%, which would make it about 11 million Americans. But I think most studies suggest that it's probably more in the range of 3 to 6 million. We know that Barrett's is increased in patients who have GERD, but many patients who have GERD have atypical or lack sort of any symptoms at all. So how do they know they have GERD, and how do you find those patients? And then the question is, does every GERD patient need to be screened, or only some? And if so, which ones? So this is a study that Doug Rex did at Indiana a few years ago, looking at patients who were coming in for a colonoscopy. He said, hey, I'm just going to do an upper. Tell me if you have symptoms of heartburn or not. And when they looked at it, they found that 8.3% of patients who had heartburn had Barrett's, but so did 5.6% of those who didn't have heartburn. And it turns out for short segment Barrett's, the numbers were almost identical, 5.7 versus 5.2%. Now, there was a difference in between long segment. You see 2.6% versus 0.4%. So it was about 7 times more likely to have long segment if you had symptoms than compared to not. But again, the majority of patients have short segment. The overall percentages were not different. This is not unique to that study. You can see there are several other studies here. The Rex study is the second one down. Another study was 2% versus 1%. Another study was 20% versus 15%. So you see here that in general, the point being is that you'll see a lot of patients who have no GERD symptoms who will have Barrett's esophagus. So simply using a strategy based on GERD may not necessarily be the most effective. And this is what I refer to as the Barretts Iceberg, and that we have these sort of a small number of patients that we know have Barrett's, but the vast majority of patients who show up with esophageal cancer really never knew that they had Barrett's. I mean, the most common presentation is sort of a T3N1 patient who had dysphagia and has advanced cancer. So how come we didn't know about these people in advance? And that sort of fits, there's a study from Olmsted County, Minnesota, where the Mayo Clinic is, showing that at endoscopy, it was diagnosed Barrett's 22.6 out of 100,000 patients, but at autopsy, it was much higher, 376 out of every 100,000. And as I've told you, that GERD is not present in the majority of Barrett's patients, 60% in a European population study. And a Kaiser Northern California study showed that only 23 out of 589 patients who got diagnosed with esophageal cancer knew that they'd had Barrett's for even 6 months. So the problem is we're not finding these people in time. And that's really the question we have to ask. So what's our current strategy? Well, we take GERD patients, and if you are particularly men over 50, Caucasian race, prolonged symptoms, nocturnal reflux, hiatal hernia, elevated BMI, tobacco use, intra-abdominal distribution of fat. These have all been sort of proposed as risk factors. And so the idea is that you don't screen somebody who has one of these things, because that's an enormous number of people. You screen multiple risk factors, and it doesn't really say exactly how many. But again, it's a weak recommendation based on the grade evidence criteria, and it's a low to moderate quality evidence. So we really don't have a lot of good ideas regarding exactly whom to screen. This is a model that came out of the University of Michigan that sort of tries to improve upon just screening based on GERD. And they looked at people really who had, if you had weekly symptoms of GERD, increased age, and an elevated waist to hip ratio, and had tobacco use, they found that the area under the curve you see there is 72%, compared to just 60% for GERD. So with GERD, you'd miss 40% of the patients. With this model, you'd only miss 28%. So some incremental improvement over just screening based on GERD. So, okay, so you decide, have a patient you think needs to be screened. What should you screen them with? And your choices are standard endoscopy, unsedated endoscopy, capsule endoscopy, which hasn't been shown to be very effective, unfortunately, and unsedated endoscopy, depending on the study, is variably tolerated. Cytosponge, which is actually, I'll talk about in a minute, something that will be one of 4 U.S. centers to start this summer, or something else, maybe a blood or salivary test. So I'll talk a little bit about the cytosponge. This is a capsule that basically is on a string. You can do it in the office. You basically swallow it. It takes less than 10 minutes. It can be done by a primary care physician. Once it gets in the stomach acid dissolves this thing, and it sort of becomes this sort of spherical sort of pad. And then as you pull it up, it scrapes off the tissue of the distal esophagus, and it tests for a very specific factor for Barrett's called trefoil factor 3. And so this was really developed in England. And so what we've learned is that you can convince 99% of the Brits to do this. Whether we'll have the same results in the United States, I'm not sure. We'll find out. But 3% of them were diagnosed with Barrett's. For even 1 centimeter of Barrett's or more, the sensitivity was pretty good, 73%, very good specificity, 94%. And most importantly, when you said that, well, I'm looking for longer segments, 2%, 2 centimeters or more, the sensitivity went to 90% without a drop in specificity, which is what you normally see. You start increasing sensitivity, you lose specificity, but not here. So it shows some promise. We'll be enrolling patients in this summer, and we look forward to seeing how it works in our population. So when do you start screening patients? Well, we really don't have any real good ideas on this. It could be based on duration of symptoms, based on age, based on the presence of certain high-risk characteristics. The short answer is nobody knows. We don't really have a good sense. Once you develop a certain number of those criteria I mentioned, we typically do it, but it's really not based on, any evidence. So the last is if once I start screening somebody, do I need to do it again, and if so, how often? And there is some better data on this, and there's actually a recent study in clinical gastroenterology and hepatology that supports this. This was using the CORI National Endoscopic Database over a 5-year period, looked at 24,000 patients who had an EGD that was negative for BE, and then had at least one subsequent EGD during the study period, and said, well, how often did they end up getting a second, endoscopy that showed Barrett's within that 5-year period? And it turned out it was about 2.3% of the time. And that was more often in men than women, as you'd expect, because certainly we know that Barrett's is more common in men. Interestingly, if you had esophagitis at the initial endoscopy, you would find Barrett's on a follow-up 10% of the time, whereas if you had no esophagitis, it was only 1.8%. So the only reason to sort of rescreen somebody, frankly, is somebody who had esophagitis on the initial exam, and one could argue you should sort of relook at those people some ways anyways to make sure their esophagitis is healed. So in summary, for screening for Barrett's, the utility for screening for Barrett's really depends on the accuracy and price of the screening technique. I think endoscopy-based screening will be difficult, whether we'll have some luck with the cytosponge or with some other screening technology that's salivary or blood-based remains to be seen. And we also have to have, once we make the diagnosis, we have to have a good treatment plan that will sort of make it worth finding these people. If we don't, what's the point of knowing? Screening for Barrett's based on GERD symptoms appears to miss probably the majority of patients with Barrett's. And then we may need to take a broader approach, potentially with a less expensive option for screening, to identify the majority of patients so that we don't see these patients primarily present with dysphagia and advanced cancer. And current data suggests that there's a limited role in low yield for repeat screening for Barrett's once you do it. If you're going to do it, it's probably in the setting of someone who had esophagitis. Okay, so moving on, we'll talk about who and when to ablate and eradicate. So these are, again, the primary modality, the best studied by far is radiofrequency ablation. There are some other techniques, cryoablation, APC, but they've had very spotty data or very limited data, and so I'm really going to focus on the RFA data. And this is a very busy slide, but I want you to focus in the red box. The column on the left, CRIM, is how often did you get rid of every intestinal metaplasia cell. The column on the right, the CRD, is how often did you get of all the dysplasia. And the short answer from this, if you pool it, is you can get rid of all the Barrett's in about 80% of the patients and all the dysplasia about 90% of the patients. And that's the number you should tell your patients when they come in the office and they ask you, how likely is this to work? So the natural history of high grade, we'll talk about which indications there are. I think in 2015, there's no question, virtually every society, including surgical societies, have said that the endoscopic approach and management of high-grade dysplasia is first-line therapy. We know that these patients have a 6 to 10% progression to cancer per year. A meta-analysis put it at 6.6%. And in the most rigorously done studies where you sort of have very rigorous confirmation of pathology and very rigorous protocol biopsies, this was the New England Journal AIM dysplasia trial, which we participated in, the progression rate was 19% at 1 year. And I would argue that was probably the most rigorous sort of pathologic progression study that's been done. What about low-grade dysplasia? There's been some controversy about this in the past. There's been some variable data. Some studies suggest that the risk of progression to high-grade or cancer in a 1 year period is around 3%. 3 studies suggest that. 1 study was much higher at 12.7%. And a meta-analysis of studies, which is the one on the bottom, suggests that it was quite low, 1.7% risk per year to go to either high-grade or cancer, which is not that much higher than for non-dysplastic Barrett's. However, more recent data suggests that most patients who have low-grade dysplasia actually have inflamed non-dysplastic Barrett's, and they are sort of dilating this pool of patients, and that the number of patients who truly have low-grade, when confirmed by an expert, is probably only 1 in every 6 that are initially diagnosed. So this is a real small subfraction, but that subfraction has substantial risk for progression, probably about 13 to 15% per year. This is a study from the Netherlands that suggested that it was about 13% per year, and the New England Journal data was almost identical, 13.6%. So one was 13.4, one was 13.6. And if you look at a number needed to treat, the NNT for high grade to prevent progression to cancer was only 6 in the New England Journal trial, but for low grade it was only 11. So they were not substantially different. Now, to answer that question even better, a bunch of centers in Europe did a multi-center trial focusing specifically on low grade, comparing it to basically just standard surveillance. And it was published in JAMA last year. So they started with 511 patients, and they had 247 that were confirmed low grade. So right there, more than half the patients who were referred initially to the study were found not to have low grade, which shows you part of the problem right there. So out of those patients, ultimately 136 got randomized, and the protocol was that either they went surveillance endoscopies every 6 months for the first year and then annually thereafter till year 3, or they could get 2 circumferential ablations and 3 focal spot ablations up to a year. And then if there were still Barrett's, they could get a little mucosal resection, and then they took biopsies at 1, 2, and 3 years and looked at durability and success rates in getting rid of low grade. So the patients, as you'd suspect, 68 in both arms, mostly men, 80% or more, of 60 years old, on average 2 centimeters of circumferential and 4 centimeters total length of Barrett's. They followed them up for at least 2 years, had lots of biopsy specimens, at least 3 follow-up visits. And here's the money table here. So if you take a look at the ablation group, only 1 of 68 patients progressed, and that patient did go to cancer. But in the control group, 18 patients progressed, 6 to cancer, and the difference in progression was 26% in those who were watched versus only 1.5% in those who were treated. So the total NNT works out very nice. The risk difference is 25%. So again, you need to treat 4 low-grade patients to avoid 1 patient going to either high-grade or cancer. If you treat the patients who were treated, 92% were able to get rid of all the dysplasia, 88% got rid of all the Barretts, and in terms of durability, they maintained greater than 90% durability for both dysplasia and for Barrett's over the 3-year period. The trial was stopped early by the Data Safety Monitoring Board. It was actually going to go up to 5 years. So I think that we have pretty level 1 evidence. All major U.S. insurers essentially switched after that was published. So the last thing then I'll talk about is what about non-dysplastic Barretts? And we've sort of typically been told it's about 0.5% per year. But then we had 2 studies from Europe that said, wait a minute, that's way too high. It's actually only about 0.12 or 0.13%. And so that sort of made us wonder, well, how risky is this really? And there's a couple of reasons that this may be an issue. So one thing is that the European studies have routinely eliminated cancers that were found in the first year, and in one study, in the New England Journal study, also eliminated all high grades found in the first year. So if you do select out the worst stuff, at some point all those patients didn't start out with high grade, they started out with non-dysplastic. You are sort of some degree artificially sort of lowering sort of the progression rates in these studies. The other thing is, for short segment Barrett's, multiple studies have shown that about 1/3 of the time you can't confirm those patients even had Barrett's because it's either somebody mislabeled and it's actually some of the cardia mucosa, the folds still extend above that. VA studies in the US have done, there's actually 3 studies that have shown that patients with under 3 centimeters of Barrett's reliably, when looked at by experts, they won't be able to be confirmed to have Barrett's. And so obviously if you don't have Barrett's to start with, you're probably not going to develop esophageal cancer. So those are some things that we should think about in sort of why these numbers are lower. If you take a look at pooled data from several studies looking at the effect of a variety of ablation techniques, not just RFA, but APC, PDT, cryo, looking at all these things, you see the number needed to treat for non-dysplastic Barrett's to prevent 1 cancer is 45. You might say, boy, that's a lot of patients. But if you take a look at what you do every day and what's been really an unqualified success story with regards to colon cancer in this country, you need to treat 38. So 1 on the right is standard of care, no one questions. 1 on the left is highly controversial, although I would argue the 1 on the left is actually the worst cancer to get should you have it. We certainly see much more colon cancer in this country, but I think it's much, if you're going to get one of the 2 in terms of outcomes, esophageal cancer is worse. So cost effectiveness of this approach, this was a study that looked at comparing high-grade, low-grade, and non-dysplastic Barrett's. They assumed a 25% recurrence rate, which I'm going to get to, this issue of durability, and that you would have to follow every patient you ablated forever, so you couldn't ever stop. And they looked at it for low-grade and non-dysplastic, and they said 3 strategies. We're going to biopsy you and wait till you get cancer, and then we're going to operate. We'll biopsy you and wait till you get high-grade, and then we'll treat you with RFA. Or we're going to treat you with RFA up front and then watch you, which is indefinitely. And for low grade, it turned out that the clear winner was ablation, and I think I've just shown you level 1 evidence that's the correct answer. $18,231 for quality adjusted life year using an RFA upfront strategy. For non-dysplastic, the numbers are not as great, again, assuming a fairly high recurrence rate of 25%. But you can see that if the dysplastic rate goes up to a 0.5% per year, it becomes about 118,000, okay? So certainly we do know one thing that's important. This is another piece of information you can tell your patients. There is pretty good data now that for every centimeter that you have, your risk is about 0.1% per year. So in the past, when we've lumped all these people together, we were lumping people with 12 centimeters with somebody within regular Z-line. Those people are not at similar risks, okay? And so what's the best way to, I tell a patient with 10 centimeters of Barrett's, your risk is 1% per year. And I think we have some data now to support that. We don't have a lot, but we do have some reasonably good data for that. So I just showed you that, well, it's not that great the quality adjusted life year cost effectiveness for ablating non-dysplastic Barrett's, assuming some of the numbers and assumptions here. But surveillance, which is standard of care based on the current data we have for that, is about $600,000 per quality adjusted life year, okay? So it's at least 2 to 3 times as expensive as an upfront approach for treating Barrett's esophagus. Again, it detects, not prevents cancer. It leads to anxiety. When you're taking biopsies according to Seattle protocol, volumetric studies show that you're sampling 3 to 5% of the surface area. So as I tell patients, in a 100-straw haystack, I'm going to take 3 to 5 and guess what the rest of it is in there, okay? Poor compliance with has been shown with reduced dysplasia detection. And surveillance frequency hasn't been tied to Barrett's length. So we follow someone with a 0.5 centimeter of Barrett's the same frequency as someone with 10 centimeters, and I'm not sure those people are at similar risks. There's also no quality data suggesting that there's a mortality reduction from screening these patients with doing surveillance. So this is the technique that we should be typically following in patients with surveillance. This is what the guidelines suggest. For non-dysplastics, you take 4-quadrant biopsies every 2 centimeters. You do it 2 years apart initially, and then once there's no dysplasia, you do it every 3 to 5 years. For low grade, you should do it every 1 centimeter, repeated every 6 to 12 months. And for high grade, which I would argue you should not be doing surveillance on high grade in 2015. I would argue you shouldn't be doing that for low grade, but it'd be every 3 months if you chose to do that. The problem is compliance. In the United States, how often does this occur? About 51.2% of the time, based on what's being sent to pathology results and what's being compared to what's on the report. And in Europe, it's the same thing. You see that patients have, the compliance is about 80% for short segment, but only 30% for long segment. So in other words, the bigger the haystack, the fewer straws we sample, which is probably exactly opposite of what we should be doing. So how can we do better? There's a brush that's out there that may be able to increase the detection of Barrett's. You go up and down, you have a greater sampling than just taking a few random biopsies. It's been shown to increase both the detection of Barrett's in patients with GERD as well as dysplasia in patients with Barrett's by about 40%. This is a device we have at UCLA. It's a confocal laser endomicroscope, so you can essentially put the probe over multiple spots real time and only biopsy those areas where you see something that looks unusual, so you're visually kind of making your microscopic assessment real time. That may have a role, and you can distinguish squamous from intestinal metaplasia to disorganized dysplastic cells to potentially very disorganized cancer cells, as you see there. The surveillance work, and this is a very elegant study which I'm going to very briefly summarize. This was looking at 8,000 patients with Barrett's in Northern California, Kaiser, 350 developed cancer, and they looked at 70 patients who had had a prior diagnosis of Barrett's, which goes to show you that 280 had no prior diagnosis of Barrett's, which is the people under the iceberg, okay? But they looked at the surveillance history, and it was contrasted with people who were living with Barrett's. And long story short, the presence of having surveillance within 3 years had no effect on whether you died from cancer or not. The odds ratio was 0.99. So in essence, there's really no high-quality data showing that the net health outcome for surveillance endoscopy does anything. And in fact, I can guarantee you no insurance company in the country, if you were trying to propose surveillance as the standard of care today, and if it wasn't the standard of care, there's no way anybody would insure it. So the question is, what should you do for non-dysplastic Barrett's? Should you ablate it? And the question is, who's at high risk? Well, certainly, potentially people with family history, although we know that's a small percentage of patients. Longer segments, certainly I told you the 0.1% per centimeter sort of rule. Patients who have, a good length of lifespan ahead of them. Assume that most individuals may live to around 80 these days, so if you have at least 20 years of life. There's some softer indications if there's been indeterminate dysplasia in the past, badly controlled GERD, and elevated BMI in men, or hernia size. So the rationale, I would say, is that in a 50-year-old man diagnosed with long segment Barrett's, you could, in this situation, surveillance says you do one at 50, at 51, then you do it maybe every 4 years in between then, and you'd get all these extra endoscopies. You'd end up with 8 endoscopies by the age of 75. If you chose to ablate that person, they might need 3 ablation sessions, which is being sort of generous, a 1-year, 5-year, maybe a 10-year follow-up, and at that point, I would argue you could maybe stop, and you'd probably save 1 endoscopy and benefit from having eradicated the disease. So the last thing I'll talk about is to follow up post-ablation, is the durability of the ablated tissue, and the studies show that you can sort of maintain ablation. Early studies showed about 90% of the time. Recently, there's been recurrence data suggested, well, not so good. 72% in one study from Europe, 62% in one study in Europe. Another study from the US suggested it's a 33% recurrence. So, well, if it's going to come back within a couple of years, what's the point? There are several US studies that have reported this. I will sort of point you to the bottom study from Northwestern, which only reports a 3.7%. And that's because they've had very aggressive pH control at Northwestern, where they've really married their physiologic program along with their ablation program. And I think, again, it's very important to control sort of acid reflux and gastric reflux back to achieve good results here. 95% of recurrences, when they do occur, are not as bad as before. So if you had high grade, you're going to have something typically less than high grade. worse baseline Barrett's and had higher rates of recurrence and earlier rates. So the worse dysplasia you have, yes, you're more likely to recur, and you're more likely to recur earlier. So non-dysplastics are probably the ones that are least likely to recur, high grade more. This is a meta-analysis of all the studies of ablation, and it show basically that you can get rid of Barrett's in about 80%, get rid of dysplasia in 90%, and recurrence is probably around 13%. And that's the number that I quote my patients, because this sort of pools all the studies that have looked at this. This was just published in Clinical Gastro and Hepatology. And if you're looking at who's most likely to recur, it's patients who have increasing age, if you're not Caucasian, and longer segments. So the longer segment you have, the worse dysplasia you have, as you'd probably expect, those are the people who are most likely to recur. This is a study looking at subsquamous recurrence, and I'll just sort of say, you might say, well, what about these buried glands? 15 years ago, all of these 215 patients would have had an esophagectomy. In this study, there were 3 patients who recurred. One was actually after a surgery, and the other 2 had a curative surgical resection. So I think that certainly that you do need to do some surveillance, but it's not something that ultimately should preclude, preclude doing the device. So in closing, the last couple of points I'll sort of make here. How often should you follow patients? In patients who've had high-grade or intramucosal cancer, this was a survey out of the University of Michigan, and it basically showed that most patients are surveyed every 3 to 6 months in the first year, and then every 6 months in year 2, and then annually. And then for patients with low grade, it's every 6 months for the first year, annually for 2 years, and then probably every other year till year 5. Non-dysplastic, again, there's no hard data for this, but I typically do them 1 year post-eradication and then every 3 to 5 years. And I think eventually, probably after 10 years, we're going to have data to suggest that you can stop. You could potentially stratify patients using this new device that will allow you to detect if there's buried glands. So if you do this technique and show that there's nothing underneath, you may be able to potentially do less surveillance or stop surveillance sooner. And that's a research project that we're sort of in the process of undertaking. So in summary here, I think the key questions are, how do we best screen and identify patients with Barrett's? I don't think we have the right answer, but I think it's going to require a more broad population-based approach. What are the clinical and biomarker risk factors that predict progression to non-dysplastic? That's really the key. We don't know which non-dysplastic patients progress. That's the answer we need. How can we do surveillance and do it better if that's going to be our current standard of practice? Are there risk factors that can better predict who's going to be a good ablation candidate versus not, and who's more likely to recur? What's the appropriate surveillance interval? And we're going to have data in the next couple of years to sort of give us that answer. Right now, it's mostly expert opinion. And when can we stop? Because ultimately, that's going to make this cost effective. And is there a role for chemoprophylaxis? 5 years ago, I wrote this with Pratik Sharma as sort of a goal for 2020. Unfortunately, we've not made much progress on this, but essentially, we'd like a non-invasive test that can screen for Barrett's. If it's negative, you're done. If you're positive, you'll move on the left side. You'll get an endoscopy. If the endoscopy confirms it, we'll use a clinical panel as well as biomarkers to predict your risk. Low risk we'll forget about. High risk we'll treat. And hopefully, we won't have too many people in the middle who are undergoing chemoprophylaxis or surveillance. So in wrapping up, again, I think the current screening strategy for Barrett's has not shown benefit, and unlike for colon cancer where the number has gone down, adenocarcinoma continues to go up with our current strategy. The optimal method and timing for Barrett's is uncertain, and future approaches may benefit from using a lower cost method. Endoscopic ablation should be discussed as a treatment option for all patients with confirmed, both low and high grade. And again, I think it's potentially reasonable to consider select non-dysplastic patients, particularly given the data on surveillance. Recurrence does occur after RFA, and you must follow these patients with surveillance. But future work will hopefully identify, when you can potentially discontinue surveillance and how often you have to do it. Then I'll stop and take questions. Thank you.